Hello everyone. I really hope that you all are doing fine and your families and everybody is fine. So we need to start with this topic today, which is the temporomandibular disorder, and hopefully we will cover the orofacial topic today only. So let's begin with the temporomandibular disorder. So it is very important topic. You will get at least one scenario from this topic for sure, 100%. Okay, so TMD is a collective term for a number of clinical problems that involves the masticatory muscles. So temporomandibular disorders means it is a collective term and it involves the masticatory muscles or the temporomandibular joints. Okay, and associated structure. So it is the disorder which is the term given to any problem, whether it is in the muscles, whether it is in the joints, or any associated structures. They can be classified into subtypes. So TMD has two subtypes. First is temporomandibular joint disorder, and the other one is the muscle disorder. Okay, then how you can diagnose it, how you can make the accurate diagnosis by doing the history, examination, and imaging. Okay, and what would be the sign and symptoms of these problem like TMDs that the patient would tell you and what you will notice? So the symptoms are the things that patient tells you and signs that you notice. So patient commonly says there is a pain and restriction with mandibular function, pain in and around the ears and masticatory muscles, headaches, neck pains, limited jaw opening, joint sounds, clenching of teeth. So patient may complain any of these points. Okay, so this is very good question to ask. If you are suspecting any TMD in any of your patient, you can ask him whether you feel that your cheek muscles are sore when you wake up, or any headaches, neck pains, or any limited jaw opening, joint sounds, or clenching of teeth. Okay, then the uncommon symptoms could also be related, which are bit uncommon but can be a possibility, which are reduced hearing, changes in occlusion, toothaches, altered sensation in the face. Okay, which means the paresthesia or a feeling of swelling. So signs would be what you as a dentist you will notice. So when you will try to feel in that area, you will feel that the area is tender, tenderness of the joint and the muscle during movement, and sometimes joint sounds, which is clicking, clunking or crepitus during repetitive opening and closing of the mouth, as well as lateral and protrusive movement. When you will ask your patient to do these movements, which are opening, closing, and lateral movements, then there might be some sounds and deviation on opening of the jaw. So these are the things that you may notice in your patient, and these are the complaints that your patient would come with. Okay, then temporomandibular joint sounds are not an indication for treatment unless associated with pain or dysfunction. Then what? So these are the sign and symptoms. And what could be a risk factor that pose the patient to be on a risk of getting temporomandibular disorders, which include direct trauma or indirect trauma, which means acceleration, deceleration injuries, and parafunctional activities. Like if the patient is doing bruxism or clenching the teeth, that is putting load on the joint and the associated masticatory muscles, they will get tired and they will cause pain and dysfunction. Then psychosocial issues as well. So all these points are interrelated. So when the patient would be in stress or he's anxious, then only he would grind or clench his teeth, and that would lead to TMDs. Malocclusions has not been shown to be a risk factor for temporomandibular disorders. Habits such as lip and cheek biting, biting fingernails, chewing gums, and smoking can perpetuate an existing TMD. So these things like cheek biting, lip biting, fingernail biting, and chewing gums, these things can like perpetuate or accelerate the existing TMDs, but they are not the cause of the TMD. Chronic temporomandibular disorders are often associated with the psychological disorders, and how you will manage the patient. So you have taken the history where you have known the patient's symptoms, you did the examination and you find out the signs, and now you are on the stage of management. The aim of TMD management is to control the patient's symptoms rather than that to achieve the cure. Then treatment goals should be tailored to the specific diagnosis and may include reducing pain and adverse loading, restoring mandibular function, and resuming normal daily activities. Then management strategies are conservative and can include: first, you need to advise your patient that uh, this thing can be treated and do not stress out due to this problem, because if you will stressed out, then you will again do the bruxism or clenching, and that would be a very problematic issue. Then give your jaw some rest. Using strategies such as dietary modification, try to eat only soft food for some days so that your jaw will rest, and avoid extreme jaw movements like chewing gums or yawning or singing. Yeah, and try to massage with the warm packs to the to the temporomandibular joints and cheeks several times per day. And cold packs, they can use it if there is any sign of redness or swelling. It means if there is any sign of inflammation, then they can use the cold packs. Otherwise, warm packs would help them with the blood flow, and it would help in relieving the pain. Then behavioral modification, we need to find out what's the cause of stress and need to do some individual or group counseling. These things we won't be doing, so we can refer them to the physiotherapist or whoever can help them best, or their GP as well, because they do have certain strategies to help the patient relieve the stress, such as the cognitive behavioral therapy or other therapies like hypnosis. And yeah, so they do, GP does have certain strategies, and the physiotherapist, they can do the regular treatment with the muscle stretching and massaging. And you can also make a custom made splint for the patient, okay, which is mainly the Michigan splint, which is made to protect the teeth from the load and to reduce joint loading, muscle activity, and pain. Splints are generally worn at night and protect teeth from the effects of bruxism, because bruxism generally happen during the night time. So if your patient is wearing this full coverage, custom made, so do not advise your patient to buy the splint from the supermarket. Always these you need to take the impression, and then you need to make a custom made full coverage intraoral occlusal splint for the patient that would help him in protecting his teeth and joint. Short-term use of drugs as well discourage patients from relying on drugs alone to treat the symptoms of temporomandibular disorders because of their chronic nature. So you should not, because this type of pain, as we were reading here in the previous topic, so the acute dental pain is in nociceptive in nature. In that case, we need to prescribe the patient medication. But these TMT problems, they are chronic and they are neuropathic pain. It means they are chronic in nature. If we will advise the patient to take the regular medications, so it would be for a very long period because of this chronic nature, right? So it would and in this scenario, you need to discourage the patient on relying on the drug. You need to encourage him to do like these conservative methods, like jaw rest and warm packs, then exercising or the splint. But sometimes we may need to prescribe some painkillers such as analgesic, relaxants, anxiolytic, and anticonvulsant drugs. So these are all of the drugs that are prescribed by their GP. We won't be prescribing them muscle relaxant as a dentist. Okay. And because the treatment for the TMD, as this is chronic in nature, this problem, so it does involve multi modal approach. So we need to take the help from the physiotherapist, from their GP, or from the dentist, and sometimes these TMDs could also be due to any mouth breathing, or like if there is any problem in the body, if the oxygen supply is not enough, so we may also need to take the help from the specialist. They can make certain appliances for the patient so that they can sleep better. So it is bit tricky topic. Then an acute exacerbation of chronic temporomandibular disorders can be treated with ibuprofen or paracetamol. To avoid any permanent effect on the position of the teeth, it is essential that the splints are custom made and full coverage. The fit of the splint should be reviewed regularly and adjusted when required. If conservative measures are inadequate and pain and dysfunction become severe or chronic, then you need to refer the patient to the oral medicine specialist or oral and maxillofacial surgeon. So, as a general dentist, you are only doing these few steps. First, jaw rest, then avoidance of extreme jaw movement, warm packs, behavior modification, that you need to find out what is the cause of their stress, then exercising and splint. Okay, and short term use of drugs. After that, if still the patient symptom does not resolve, then you are referring him to the specialist, which is the oral medicine specialist or the oral and maxillofacial surgeon. And there is some evidence for the use of botulinum toxin, which is the Botox, to manage the symptoms of the TMDs when conservative measures are inadequate. Ensure patient understand that botulinum toxin is not a cure for TMD, but may be used as a part of the overall management strategy. So by giving the Botox injection, you cannot treat the TMDs. It will only help with relieving the pain and as a part of the overall management strategy. The use of Botox for TMD is off label. Dentists require additional training to administer Botox. It is recommended if the recommended doses and protocols are adhered to, the incidence of adverse effects are adhered to, the incidence of adverse effects is low. Local complications include, like there would be some stinging during injection, bruising at the site of injection, and excessive muscle weakness. Adverse effects associated with inadvertent injection of botulinum toxin into non-target tissues are rare, but can include alteration in smile and temporary dry mouth. Systematic adverse effects include an influenza-like syndrome that is transient and hypersensitivity reaction. Then surgery for TMD is rarely required. Only consider referring the patient for a surgical assessment if symptoms have not responded to conservative management and there is definitive evidence of internal joint rearrangement. Like you just need to do the conservative treatment, and after that you need to refer the patient to the specialist, which is the oral medicine specialist or the oral maxillofacial surgeon, and they would do the imaging, which would be the best imaging for the temporomandibular joint is the CBCT. Then burning mouth syndrome is an oral sensory disorder without a detectable cause. It is diagnosed when other conditions that can cause an oral burning sensation have been excluded. So it is a diagnosis of exclusion. There was one scenario on this topic as well in the exam. Burning mouth syndrome is more common in women, with the highest prevalence reported in women older than 70 years. The onset of burning mouth syndrome may be sudden following a specific event, like, for example, dental treatment, a significant increase in personal stresses, or gradual and unrelated to any obvious event. Okay, so so it is generally seen more commonly in the women and mainly who are older than 70 years. Okay, and it can start suddenly even after a dental treatment or any increase of any personal stress. And it is often poorly diagnosed and managed. Although symptoms of burning mouth syndrome vary, the characteristic symptoms is a burning sensation of the tongue and less frequently the hard palate as well, and mucosal aspects of the lips. So there would be burning sensation from the tongue, which is the most common, and sometimes hard palate and lips as well. Symptoms can cause minor inconvenience or in severe cases prevent patients from conducting normal daily activities, and in extreme cases the patient may exhibit suicidal tendencies. So these burning sensation can vary between the patient. Sometimes it is mild, but sometimes it is very severe that can even lead to patient to think about the suicidal tendencies. Most commonly, the burning sensation is mild in the morning and increases in intensity as the day progresses. This presentation has the best diagnosis. Like other signs and symptoms associated with the burning mouth syndrome include the parafunctional habit. The patient might be having any parafunctional habit, which means that he might be unconsciously rubbing the tongue against the adjacent teeth and the hard palate, which can cause traumatic abrasion of the filiform papilla on its dorsal surface. And first point was burning sensation. Second point is parafunctional habits. Third is patient might be having dry mouth and halitosis and dysgeusia, which means the metallic taste in the mouth. So bad smell, bad taste, dry mouth, parafunctional habit, and burning sensation. So these would be the sign and symptoms. Then how you will make the diagnosis and management. Burning mouth, and if burning mouth syndrome is suspected, the initial workup is extensive and requires a detailed clinical history, including dental, medical, and medication history. Because burning mouth syndrome is a diagnosis of exclusion, other causes of the patient's symptom must be ruled out, such as local causes, systemic causes, hypersensitivity, or drugs. Okay, so as this was diagnosis of exclusion, you need to find out any other causes of the burning sensation on the tongue. For example, if there is any fungal infection happening on the dorsal surface of the tongue, that can also lead to the burning sensation. So you need to rule that out. How you can rule that out? By performing the test, the swab test, to find out if there is any candidal hyphae on the swab. Then some practitioners are use questionnaire to assess the impact of symptoms on the patient's mood and quality of life. The management is generally complex, and the most important component of management is helping the patient to understand the condition, and that is that the burning mouth syndrome is a chronic neuropathic pain syndrome, and some patients may improve with discussion and counseling alone, and other management might be some lifestyle changes such as relaxation therapy, time management, exercise, community group participation, or sometimes they may need to take some particular drugs such as psychotropic drugs, TCAs, anti-epileptics, or clonazepams Pharmacological management is the treatment chosen by most patients and requires specialist referral. So you just need to find out like the burning mouth syndrome. If you are suspecting that, then just refer the patient to the specialist. He would deal with them better. All right, so we are done with this topic here, and tomorrow hopefully we will start the other topic. All right, guys, thank you so much for watching my videos, and thank you so much, guys, for showing your support. I really, feel very good when you all are messaging me. We are waiting for your videos, and your videos are very helpful. Like, this is the best thing. Thank you so much.